So we're going to be talking about a particular study that is from the Partners in Health program in Malawi. It's looking at data quality for the Community Health Worker program in Nano District, Malawi. This is the district that's supported by Partners in Health in Malawi. And it used LQAS as its design to look at data quality. So just as a bit of a background, the Community Health Worker program in Malawi is very similar to the Community Health Worker program in Rwanda. And people believe that this data could inform policy and program management. So we're getting all kinds of information collected in the Community Health Worker program that would be very useful for us. However, the level of data quality is unknown, and that's a bit generous. All of the evidence at the time was that the quality was not very good. You know, they would get these reports in, and the numbers would not make sense, and there'd be missing data. And so they didn't have formal assessment, but their evidence was that the data quality was quite poor. So the goal of this study was to describe the results of the data quality assessments pre- and post-intervention, and to describe how they developed the interventions to address data quality in Nano District. So I'd like you guys to take a few minutes in your teams and to review the methods section of your paper. And based on that, I want you to talk about what is the area of classification, what was the sample size and the decision rule for the LQAS system, and what 4 parameters were used in the design of the system. So what was their upper threshold, their lower threshold, and their thresholds for misclassification. Nano District has 21 health posts. I'm not going to draw all 21. Nano District has 21 health posts, and they didn't have the resources to go to each of the 21 to classify each. So instead what they did is they said, these 4 health posts together, I'm going to call you a cluster. So this is cluster 1. These, I think the next one was 5 health posts together. I'm going to call you cluster 2. And they grouped them together so that they had 5 different clusters of health posts for classification. So they didn't have the resources to classify each of the 21 areas, so they grouped them in as neighboring health posts and classified 5 different clusters of health posts for classification. So in terms of classifying an area, remember each LQAS system has a sample size and a decision rule. What was the sample size and decision rule that they used in this study? 25 for the sample size, and what was the decision rule? 5. Okay. So what they did is they sampled in reports, they sampled 25 reports. They counted the number of reports with poor data quality. And in this study, the way they defined poor quality is they went back and they looked at the register. And if the register said there are 5 children under 5, and the report said that there is 4, they said it is poor quality because they did not agree. So they counted the number with poor quality, and they compared it to the number 5. If fewer than 5 had poor quality, then they said this area has good data quality. If 5 or more had poor data quality, they classify that area as having bad data quality. You'll notice that this is flipped. Before, when I talked about this, I said if X is less than D, you say it's low, and if X is greater than or equal to D, you say it is high. I just want to point out, so this is not confusing, that this is the same as a system where your sample size is 25, and your decision rule is 21 if X is good reports. So here we are looking for 5 bad reports. If we see 5 or more bad reports, we call it bad. We could have looked for 21 good reports. If we saw 21 or more good reports, we would have called it good. They're the same systems. The team thought it was easier to count to 5 than it was to count to 21. Okay, so you could have done it either way. They counted the number of negative reports and called them, if there was 5 or more bad reports, the area was classified as poor data quality. So remember, to get to the sample size of 25 and the decision rule of 5, there's 4 parameters they need to specify. What was their definition of good data quality? So if you see 90% or better agreement between the registers and the reports, you want to call it good. What was their definition of bad data quality? 70%. And is their ability to classify as good or bad perfect? Is it a perfect system? No. What percent chance are they willing to make a mistake? Less than 10%? And at this example, it was on both sides. So this is the threshold. So that's the maximum. So less than 10%. So that 90, 70, and the 10% thresholds is what led to the sample size of 25 and the decision rule of 5. So you can change these things, but it would change your sample size and your decision rule. So this was the first classification of the 5 clusters. 4 of the 5 had low data quality, and 1 of the 5 had high data quality. It's frustrating, right? We want our programs to be doing good. And this first assessment says that 4 of our 5 areas are struggling to have good data quality. And then I say, okay, now what? What can we do to fix this? So let me describe to you what they did in Malawi. They went to the 4 areas that had poor data quality, and they said, what are your problems that you're facing? And they said, we have competing demands from the ministry. They're asking us to immunize children, and they're asking us to accompany mothers to the health center, and they're asking us to see if the under 5 nutrition is low. Malnutrition is poor. So they have all these things they have to do, and then to get good data is a problem on top of it. And they also said they did not have the equipment for aggregation. They didn't have calculators, they didn't have computers, they didn't have the tools that they need to aggregate the data. So based on this, they worked on tools and responsibilities. To see if they're sufficient. And then they went to the site and they said that had good data quality and said, what are you doing different? How are you able to get good data quality when everyone else is struggling? And it ended up, they did not let the community health workers aggregate the data. They actually took all the registers from the community health workers and gave them to a site supervisor who did the aggregation. And the site supervisor was someone who had more education, he had more money, he was paid better, he had fewer responsibilities in the community. So they took these 2 pieces of feedback and they shifted aggregation to data assistance. They said, maybe our community health workers don't have the time. Maybe the site supervisors don't have the time, so we're going to hire people just to help with data aggregation. That's going to be their primary responsibility. And this is what happened. So this was the baseline assessment. And after 4 months, 3 of the areas that had low data quality shifted to having high data quality. And after about 9 months, all 5 areas had high data quality. So yes, if you just look at this, it can be very frustrating. But if you go in and make resources available to areas that are struggling, or you go in and you study the area that is doing well, it is very easy to see change quite quickly in terms of data quality. Now the question is, does this matter? So this is looking at what was reported before the intervention. This is when they did the intervention, and this is what was reported after the intervention. So it is the proportion of pregnant women who did not have an ANC visit. And that went from 25% in January to 0% in February to 250% in March. So you can look here, when the data quality was poor, the aggregated data did not make sense. It was values that could not be possible. It was all over the place. However, when you look after the data quality intervention, all of a sudden there are much more consistent data. It's much more believable once they have addressed the poor data quality. So hopefully if you're doing LQAS, you find the problems and then you find solutions and you can see changes quite quickly. So I'd like us to just take a few more minutes with this study. So based on the discussion of this study, and based on your own ideas, what do you think the strengths and weaknesses of this study are? So where do you think this study is good? And where do you think this study could have been done better? So just give me some general ideas of what did you think were some strengths and weaknesses of this study. You get these classifications in different areas which help you understand who's doing well and who's doing poor, and you can design interventions to address it. So that definitely is a strength. A weakness is a small sample size, right? So our ability to have much confidence is limited. Could a small sample size also be a strength? Yeah, from a financial point of view, could you imagine if you had to do this in 100, sample size of 100? It would be very difficult, okay? So from a statistical point of view and confidence, a small sample size is bad, but from an implementation point of view, a small sample size is good. So this idea of looking at an area that is doing well, we call that best practice study, or it's also called positive deviance. So I'm going to look at, we've got bad, but then I have this one area that's good. So it is a positive deviant, and I want to know what's special about that area so I can improve all areas. This is much easier for decision makers than giving them confidence intervals and p-values and things that take a little bit more training to interpret. So absolutely, I think that this is a much simpler system. It's very actionable, and in a couple of weeks I'm going to have you guys start to think about the studies that you would want to do if you had the time and the resources to do studies. And I think for a lot of you who are in programs, thinking about action plans is really useful. It takes fewer resources, and to have a better study or better classifications, we would have to spend more money. Another weakness they point out, I just want to mention because it really goes back to what Nadine said at the very beginning. So one of the benefits of LQAS is I can see how I am performing relative to my targets, so relative to my thresholds. But this system is designed for specific targets, 90 and 70, right? So they said 90 and 70 is their targets, and it's designed for that. If Amable comes in and he says, no, it's not 90-20, or sorry, 90-70, it's really 95-75, this system would not work for him. These classifications would not work. So it is for your program, but if someone wants to look at different thresholds, the classification system does not work for them necessarily. And that's a weakness. So I want to just end with one point. This is the first time, and we are not talking about confidence intervals, and we are not talking about p-values, but the uncertainty is there. The uncertainty is hidden behind in these misclassification thresholds. So I can change my level of uncertainty and it will give me a different sample size. Just because I say it has high data quality, it doesn't mean it's perfect, that my classification is perfect. But I can tell you that I reduce my probability of mistake to less than 10%. Okay? So again, I just want to emphasize, it's not that it has perfect certainty in the classification, it's just the uncertainty is hidden behind our sample size and decision rule.